Okay, on June 29th, House Republican leader Kevin McCarthy announced the formation of the Healthy Futures Task Force, an initiative by select House Republicans to craft a patient-focused health policy agenda for the future. I serve as a member of this task force and specifically serve on its security subcommittee, which will study our nation's public health infrastructure and pandemic preparedness in order to build on what works and to improve what isn't working. Today, as part of my role in the task force, I'm hosting a virtual roundtable on public health. I'm joined by the Oklahoma State Department of Health, the Oklahoma City and County Health Department to discuss the public health needs they encounter and their missions and challenges to addressing these needs. As the boots on the ground, so to speak, their input will be influential in shaping the recommendations the Security Subcommittee puts forward. With me today from the Oklahoma State Department of Health is Commissioner Lance Fry. Commissioner Fry has served as the department's commissioner since April. Prior to leading the Oklahoma State Department of Health, Commissioner Fry served in the U.S. Air Force as a member of the Officer Training Corps, serving as State Air Surgeon for the Oklahoma Air National Guard, and as the Senior Medical Officer and Advisor to the Adjutant General of Oklahoma for all Oklahoma Air National Guard medical issues. He was also deployed in support of Operations Enduring Freedom and Iraqi Freedom. Representing the Oklahoma City and County Health Department are the Chief Operating Officer, Phil Maytubby, and Chief of Public Health Protection, Blaine Bolding. Chief Operating Officer Maytubby has been working in public health for over 30 years. I might also add he's an old friend of mine and old family friend, quite frankly, a very long standing. His preparedness and response experience dates back to the 1995 Oklahoma City bombing, and he's been an incident commander for public health for numerous events in the Oklahoma City area, such as tornado strikes, ice storms, 2008 hurricane evacuation shelters, and multiple infectious disease outbreaks. Chief of Public Health Protection Bolding began his career in public health preparedness in 2007 as the Logistics and Strategic National Stockpile Coordinator for the Oklahoma City/County Health Department. At the end of 2009, he began serving in the role as the Administrator of Emergency Preparedness and Response. Currently, Blaine is serving in the role of Chief of the Public Health Protection and is the Incident Commander for the COVID-19 response. I'd now like to hand over the gavel, so to speak, or the mic to Commissioner Lance Fry for a brief introductory remarks about the public health landscape in Oklahoma and what the Oklahoma State Department of Health is doing to addressing Oklahoma's public health needs. Commissioner?
Thank you. Thank you very much for inviting me today, and I'm very grateful for the opportunity to share some of the upcoming public health initiatives we're working on here in Oklahoma and how we got to where we are. So in Oklahoma, as in many states, the COVID-19 pandemic highlighted many needs within our public health system. Going to this pandemic, most public health experts had trained for a long time and known that eventually we would have a pandemic, but we really, even through all that, we weren't prepared for the magnitude of this pandemic. As a result, agencies like ours felt really unprepared for this, and it really highlighted a lot of the breaking points within our systems and difficulties that we had. So as we moved through this, one of the first things we realized was it was bigger than any one agency. It really required all Oklahomans and all agencies to kind of come together to have the response that we needed to get through this. So we had a multi-agency coordination center that was stood up where multi-agencies, we had everyone there 7 days a week, where that enabled us to have better real-time communication back and forth and coordination of efforts. We also reached out and developed some public-private partnerships that helped us be able to react in a timely manner that was necessary to really be competitive in what we needed to do in order to make a difference in the state. What we learned was that we had antiquated technology. We had not, there really hadn't been the investment in infrastructure that we needed in the state. With that, we had difficulty with procuring supplies that we needed, testing supplies and PPE. We had never really established those relationships with vendors in order to be able to compete with the worldwide market when everything was in short supply and everyone was competing for the same assets. And we had to really start from scratch in order to develop something very quickly and do it in a way that would allow us to move at the rate that the private sector could move, and do it efficiently enough to be able to get the supplies in to prepare our healthcare system. That was done a lot through some of those public-private partnerships that allowed us to move in that manner. We also realized that with the antiquated technology that we had, it also meant that our data, our ability to obtain data in a real-time manner that would help us make a difference in our decision-making was limited. So all those areas were major areas that we had problems with based off of the strain that was put on the system through the pandemic. Right now, because of all that, we've looked back at it, lessons learned, and I think that right now, collaboration was something that we realized that was incredibly important in order to make a real difference in the state. And we're able to actually look at where we are and realize that we are at a critical point in the future of public health in the state of Oklahoma. You know, the eyes of Oklahomans and everyone in the world really realizes how important public health is now, that without a good public health infrastructure, we're going to have issues again in the future. We also have the support of our legislature, when we have support of our governor, and we have one-time funding available for us to help us develop the public health infrastructure of the state of Oklahoma that we need. So, you know, we want to continue to be innovative and bold in the way we think. We really have the opportunity to be the authors of the future of the state of Oklahoma of public health right now. So we're trying to meet with stakeholders and assess the needs, but also meet with groups of leaders in public health that can be innovative and bold in the way that we project what the future of public health should look like, and then be very thoughtful in the way that we use the money that is coming through to us in order to develop that public health infrastructure that we need in order to make real generational change in the state of Oklahoma. We realize that this is a one-time opportunity, and we want to make sure that we take advantage of it, but do it in a very thoughtful manner. Thank you.
Before I turn to other two, thank you, our two guests. For what's worth, I've sat through a lot of hearings on these kind of issues that you raised in your testimony, and the experiences you've had are very typical to what other healthcare commissioners are having in other states have had all across the board, from the mentions you made to antiquated technology. That's true throughout our entire national system. You know, the need for partnerships, frankly, the rethinking of what we need in terms of stockpiled equipment and everything else. So it's interesting to me how much your remarks, frankly, mirror what I hear when I talk to people that hold comparable positions of responsibility to yours in state after state. With that, Commissioner, let me turn now to Chiefs Maytubby and Boulding for their opening remarks. Phil, let's go to you first.
Good to see you, Tom. Not much, you know, a lot of similar comments to what Commissioner Fry put out there. You know, we were unprepared for the magnitude of COVID-19. And I know we're going to discuss this later, but a lot of it has to do with funding of programs. You know, some of our programs their funding levels been cut in half over time. And that's what the specific funds are, the ones that were going to prepare us to be prepared for disasters. So we started behind the 8 ball because we were already understaffed and basically in maintenance mode. So, I hope we can get something there. On a positive note, Tom, we're really starting to see vaccination pick back up again. So that's a good thing. I'm hoping that people are seeing what is really going on. And I wanted to talk also a little bit about, we've got to find a way to deal with the misinformation. Misinformation is literally killing people. So how do we deal with that? I think that's probably enough for me. I don't talk a lot. So,
Well, I'm going to draw it out from you a little bit more in a little bit. But Blaine, let me turn to you, and we'd be very interested in any opening thoughts or comments you have.
And again, some of that kind of echoes what you already heard from Commissioner Fry and Phil a little bit, but some of that, and really Commissioner Fry hit on it. Now we have one-time funding. We always get the funding when it's response time, not the preparedness time to have what we need. And I think that's what it is. Just like Phil mentioned, we were understaffed. But even so, if we had a proper emergency preparedness program, you can train your entire public health staff a little bit better, go into community resiliency, those kinds of things, but also have the infrastructure. One of the limitations, and I know we'll get into that with some of these questions probably on some of the public health preparedness funding, we used to make up for way years ago with the OASI funding and MMRS funding, but is infrastructure or even vehicles. So right now we're looking at taking mobile clinics to the community. That's how we can respond, or even building what we built out of our own funding here is a drive-through clinic all ready to go. But if you can have some of this infrastructure, or we talk about resourcing PPE, as you mentioned, or if that's counter medication as well, counter medical countermeasures as well. If we need to stockpile those, rotate those. We already have pretty good partnerships, luckily, here in Oklahoma. We're one of the best responder states, so that really helps. But having some of these things in place for communicate. One thing we talked about, the digital infrastructure was way outdated. I don't want to beat that, but that was a huge hindrance, and our manpower had to increase probably 5-fold because of that. And so if we really want to do things quickly, have transparent and up-to-date information so that we can have proper situational awareness to make good decisions, but also to inform our elected officials, those digital platforms across the board, nationally, state, locally, have got to be fixed.
Well, for what it's worth, then I'm going to move to specific questions. It's one of these woulda, coulda, shoulda things, but we actually had a hearing on both lab capacity, digital capacity, literally the ability to marshal information. So as Commissioner Fry said, you can make good decisions in meaningful time frame. And it was pretty evident pretty quickly in the hearing how far behind we were from where we should have been. And actually the what's called the Labor, Health and Human Services and Education Subcommittee of approach for many of these programs, NIH, CDC funding, some of the other healthcare programs that we have are lodged. The decision was being made to actually do this. I wish it had happened about 2 or 3 or 4 years earlier. But anyway, as I think all of you noted, we're all wiser after the fact, and the pandemic has shown us a lot of places where there's cracks in the system and places where we've come up short. Let me start with this. CDC's Public Health Emergency Preparedness Program, so-called PEF, assists public health departments in responding to numerous public health threats, such as infectious diseases, natural disasters, and the like. However, though both real funding decreases and through both real funding decreases inflation, funding for the program has been reduced 48% since FY 2003. What level of funding is advisable for this program, and what additional activities would increased funding permit the CDC and state, territory, local grantees to actually pursue? And Commissioner, why don't we start with you and we just kind of work around the horn. I'll start with somebody. each time we may vary it and then we'll just go in order, but we'll
Okay,
give you a first shot.
sounds good. Well, currently, Oklahoma State Department of Health received $7.9 million for this, and Oklahoma is ranked number 3 for FEMA disasters in 2019, and we've been in the top 5 for the last decade. In comparison, Oregon's ranked number 28, and they get more money than we do. They actually get 8.3 million. So we definitely could use additional funding with all the disasters that we see every year. So as OSDH, we would recommend funding really about $14 to $15 million a year is what we recommend for funding. And there are many areas that money could be used for. The city's readiness initiative could be used in order to enhance our emergency preparedness and capabilities and community resilience not only in our most populous areas, but that would trickle down through the rest of the state as well.
Hey, Phil and then Blaine.
Comments. So I wanted to point out, we kind of estimated what we would look at. It's probably pretty similar to what Commissioner just brought up. Anywhere between a 33% and 50% increase in existing funding. I mean, for us, we can actually tag that down to how many people we can hire. 80% of the funding that we get is for personnel. So the rest is for maintenance of equipment, trying to establish like these digital platforms to report on, things like that. So that's really good. But I wanted to bring up specifically a program, and it's the hospital preparedness program. That also, their funding in that program has been decimated as well. And they're the ones carrying the load right now. I mean, our hospitals are pretty much at capacity right now. And they're a good, willing partner, but they need to be funded because that money that goes to the hospital preparedness plan sets up trainings and different things that when we work together on exercises to try to ensure that we have good operational capacity and that we're all at the table. So that's, we'll just make sure we keep that in the conversation as well, sir.
You bet. Blaine?
Yeah, and I agree with everybody has mentioned so far. Part of that too is the flexibility in the spending, as I mentioned earlier. What can we use with that money? Can we do certain things to build infrastructure, or can we purchase vehicles if we need to, if they're for response? And in public health, we mentioned some of those digital platforms that are pretty common. We're talking about reportable diseases or the immunization database, or definitely a health information exchange. But as Phil brought up, the HPP funding for the RMRS and the hospitals, that funds the things we have an EM resource. That's kind of outdated too. That's how they know how to divert patients, depending on what it is, not just in pandemic mode, but if you have a burn center or trauma 1, where do these folks go? And some of the communications that they do through disasters, if there's a tornado going through, they communicate on what they call web EOC. That's kind of outdated and antiquated as well. But and also that would mean updated hospital room information. Obviously, we seem like we had trouble getting those numbers, and it's difficult to report and all those kinds of things. So helping fund those folks as well, I think it would help not just public health, but a hospital preparedness program as well.
Yeah, for what it's worth, there's also an interesting philosophical question here, and I'm not trying to be critical of anybody at any level. But I know I was stunned a number of years ago when I learned. I became chairman of this particular subcommittee. I'm now the top Republican. The public health budget in Oklahoma, at least for the public health department, something like almost 60% of it was coming from the CDC, Center for Disease Control. That, what the right mix, because you do have to have a national program. I'm not arguing every state should be on its own. Quite the opposite, frankly. I think you have to have national standards agreed, but I don't know that we've ever really wrestled with that question. I will tell you at the federal level about what the appropriate variation should be. There's other states that frankly do more, and some of them historically have done more. New York's always been a big leader in this area, but it's something we need to think through as to what the right balance is, and Congress needs to look at it that way. This is not This is not some sort of program where we're just extending local assistance out of the generosity. We really need robust systems all across the country. It's not like you can protect one part of the country without protecting all the country. So again, a lot of issues here. Let me move to my next question, and Blaine, I'll actually let you go first, so you don't have to begin by saying I agree with everything that's been said. Social determinants of health are another key driver in healthcare spending. Individual behavior and social and environmental factors are estimated to account for 60% of healthcare costs. What programs or practices, whether operated by non-governmental entities or local, state, or tribal governments or federal government, might Congress examine for implementation on a national scale? In other words, to raise the awareness of social determinants of health and try to build that into the system where we encourage better behavior on the part of our citizens to both lower costs and protect them.
Yeah, and that's good. That's a wonderful question, Representative Cole, but this is the one that Phil has prepped to answer. So I want to actually punt this one to him.
Okay.
So it's funny you bring that up because we just finished our wellness score, which is our social determinants of health measurements down to the zip code level for Oklahoma County. That measures gains and places where we haven't performed so well in the last 3-year period. So that's vital for us to move forward in our planning. We think it's a model. We've actually talked to our state, and I think they're prepared to do the same thing that we are doing right now. But to get that down where we can do prescriptive planning, like say, for example, on preparedness, we'll know which areas in there are, how many of those are Medicaid recipients, or how many of those people have have some kind of a comorbidity that we need to deal with when it comes to response. It's vital for us to shape the response to meet the need instead of just a one-size-fits-all approach. That way we'll be much more effective.
Absolutely. Blaine, do you want to add to that, or I'll go straight to the commissioner?
Yeah, go ahead and go straight to the commissioner.
Okay.
Great job.
Commissioner?
That's a great question and not an easy one to answer. When we look at the social determinants of health and the drivers for it, I know there are a lot of things that we think about in the community that can make life better for people, that would help them with disrupting some of these social determinants of health. Everything from safe places to walk, to to eat, to making sure there's no food deserts, all types of things that you can do in our communities, which we need to focus on. But we also need to focus on some of the things that start early on as root causes. And when I think about that, I think about adverse childhood events, trying to decrease the number of those in the state. Oklahoma is one of the highest in those in the nation, and we need to really develop programs to help decrease the number of those. And a part of that is you're asking about innovative programs. I think the George Kaiser Family Foundation has really one of the most innovative ones that I know of, which is called their BEST project, Birth through 8, and it's really an integrated network of different programs that starts prior to birth. It goes all the way up through their 8-year-olds, and it's really a support network that's designed to not only disrupt the cycle of intergenerational poverty, but also to develop, to support that early childhood development and growth, so to enable them to get a head start really on life. And I think that's one of the best programs I've seen just in general for a really complete integrated approach at early age intervention.
Yeah, I couldn't agree with you more. I've actually been by and seen that program with Mr. Kaiser and Ken Levitt, who heads the foundation up there, does a lot of the funding. And I brought a couple of speakers there. I brought the Speaker Boehner there, on one occasion and Paul Ryan on another. And it's just, I mean, it's amazing how much those early investments can improve the quality of life and the health of families. It's just, you know, a lot of the best ideas do come out of these things, but the scale, you've got to make them into public programs. You can't expect it just to, I mean, it's great for Tulsa and it's great for the people that get to participate, but take a major effort. Let me go on, next question. And Commissioner, since we're with you, I'll stay with you. Chronic disease such as heart disease, diabetes, cancer, Alzheimer's are leading drivers in America's $3.8 trillion annual healthcare spending. How can the CDC and other relevant federal agencies better address, again, lifestyle choices that lead to chronic illnesses and promote prevention strategies that might make a big difference?
Sorry, making sure I wasn't muted there. Sorry.
Okay.
You know, I think that, you know, to have a better approach to chronic disease, most of our programs are disease specific. And, you know, I would say a lot of, at least Oklahomans have more than one chronic disease process. You know, they may have heart disease and diabetes, you know, at the same time. And so if we could really have whole person, more representative funding that had more flexibility and also uniformity in the ability for the end user to be able to sign up to be accessible to that grant, that could make a much needed difference in the state of Oklahoma. And it would give us the ability to really treat the whole person instead of just a single disease process.
Let me, again, I'll turn to Phil and Blaine, because I'm very interested in what you guys do and think you ought to do to impact lifestyle choices, you know, at the local level, so that people, you know, look, we all know that we ought to get good exercise. We pretty much know we probably shouldn't really have chicken fried steak 3 times a week, and you know, might want to look at our tobacco and alcohol habits seriously. But you know, I'm not sure what you think you can and should do to impact those kind of choices for individual citizens. I'm very interested in that.
Well, I can give you a few ideas. You know, one of the things that we've learned, especially through this response, is that we need a better educated population. You can message all you want, but if they don't understand it, or they don't get the core concepts of what you should do, then we're really fighting an uphill battle. So, you know, one of the things that we've talked about for a long time is trying to get health education pushed further down into the educational system. So I think that would be a winner for all of us, to get people thinking about health much earlier, you know, as they're growing up, where it becomes part of them growing up, and then they don't have to learn it. So, I mean, it's already learned. But that, and then the awareness campaigns of what people need to do. I mean, you can talk to them till they're blue in the face about exercising and eating right and all that, but they need to understand enough of the core concepts of health to really understand what that means.
Blaine?
And this is one of those core issues, you know, how do you change behavior? And social and behavioral health has been one of the, you know, big mysteries to crack. And that's one that public health through academia has really worked to try to. We do know that people are relational, and as well. And like you said, most people hear this information. One of the things people don't want to hear is simple things, you know, it's not just COVID, during H1N1 or every year, is say, how do you stay healthy? You know, eat well, get plenty of rest, drink plenty of fluids, you know, wash your hands. We've been saying that for years. People want a magic bullet. But with the relational side of things, what we've done here, and we've done it at a smaller level, but we have hired what we call community health workers, who look like the community they're going to be working in and are from that community they've been working in. And so they build those relationships and start educating from that standpoint. And that's where we've had the most impact. Like I said, it's still a fairly small program, so it's limited impact right now. We would like to expand something like that, but that seems to be really making a difference when you have people in that community, that's part of that community, doing the education.
No, I don't think there's any question about that. At the federal level, one of the places where we really have invested a lot of money, and we've seen a difference over time, is like on money to educate people, particularly about tobacco, but other drugs as well. Major public advertising awareness, the work TSET has done here in Oklahoma, the agency that has the tobacco settlement money, and I think spent 75% of it on education, public awareness, research, things like that. It's also been a really great program in terms of chipping away at what's been a knotty issue, and it's overuse of tobacco. Let me ask you this: COVID-19 has called attention to some populations' distrust of public health departments and officials, whether through historical wrongs or because of skepticism of more recent public health measures. What can federal, state, and local governments do to bolster the confidence the average American has in our public health institutions? You talked a little bit about this, Phil, so let me start with you and then we'll work our way around the horn.
Sure. So, there's people need to understand that science is not that, it doesn't just sit still. It's always moving. So, we've heard a lot of people saying, well, early on, somebody said this and now it's this. Well, that's science. As science gets more evidence and things of that nature, then it moves forward. So what might have been true, say, for the alpha strain of COVID may not be true now. So we need people to realize that, be discerning, and they need to trust science. We've lost that. So where we could have help from elected officials is to try to get the confidence back in the places like the CDC and the other places that dictate policy for us, because they do truly go through a very strict and rigorous methodology of making sure they have peer-reviewed science before they come out with anything. And that is, again, we're fighting that night and day with misinformation. So whatever could be done at the policy level as far as folks supporting science would be the best.
Wayne, how about you?
Well, aside from banning all social media platforms and so yeah, and that's part of it too. Is it be clear and honest, and I think that's been some of the things early on. One of the mistakes in the pandemic was saying, well, masks don't really work, because they knew there was a shortage of masks and healthcare workers needed them, and so don't put out that kind of information. Always be transparent with the public and say what you know for certain, say what you don't know for certain, and say what you believe is going to happen, but could be changed. And that's part of building that trust and honesty, I think, is just being open and honest and transparent on that. But as Phil mentioned, we got to follow science. We got too many Google researchers that think, well, I studied, I did study. No, you didn't study this. It wasn't a clinical trial. It wasn't a peer reviewed and published. So, we got to stick to those kind of solid resources for the truth in science.
Commissioner, how about you?
Well, I totally agree with everything they've said. That the problem with COVID-19 is that, a year and a half into this, the greatest depth of knowledge in the world is only a year and a half old, and it is constantly changing as we get more data, and so people do have to have an understanding of that and trust in the process. And I think trying to keep it apolitical as much as possible is very important. It's very disruptive when you have something this emotional to people brought into made politicized, basically, and it doesn't help us move forward in a logical, scientific way. And Blaine, you're completely right. Social media makes anyone and anybody with a cell phone an expert, and it's just simply not true. And we have to rely on our trusted sources and maintain credibility by being transparent, trying to relate with people where they are, try to take the time to answer their questions and calm their fears, and arm them with credible, evidence-based information that they can make decisions on. And then, and try to, make things as easy for them to get to obtain, and easy for them to read as possible. But it's been a big issue, and there's not an easy answer.
It's very interesting to me that the members on both sides of the aisle in Congress that actually study this issue tend to come to the same point of view. And for the last 6 years, Congress, first with the Obama administration, then with the Trump administration, actually put a lot more money for the National Institutes of Health, Center for Disease Control, Strategic Stockpile than either President Obama requested or President Trump requested. Actually, President Trump, to be fair, proposed some cuts that Congress said, no, not only not going to cut them, we're going to increase these things. So NIH funding is up something like in 6 years, 39%. CDC was up about 24.5, strategic stockpile 34. And those were all pre-pandemic numbers and increases. I mean, Congress was actually looking at things like SARS, MERS, Zika, Ebola, and coming to the belief that something like this could happen. Now, we certainly weren't prepared for what overtook us, but we'd moved the right way. And again, that was in a time of great division on Capitol Hill, but very conservative Republicans on the same committee as very liberal Democrats said, this is an area where there does need to be much more robust funding and a much greater public commitment. And it's not a partisan issue. I mean, it's not as if COVID-19 or any other disease says, I prefer to prey on Democrats or Republicans or independents. There are equal opportunity viruses and diseases out there that we all deal with. And these investments, I always tell people, nobody's ever come up to me at a town hall meeting. They may say you're spending too much money in Washington, and I have considerable sympathy with that, but they never ever say you're spending too much on cancer research, you're spending too much on Alzheimer's research, you're spending too much on basic public health education. And those are things that are actually popular when they're broken down and laid out that way. They see a role for government. We just haven't done a very good job explaining it. Let me ask you this, and you, no, this is actually a different topic. Through its treaties with tribes and enacted legislation, the federal government has obligated itself to provide healthcare services for Native Americans, yet indigenous populations routinely experience poorer health outcomes than their peers. How can the federal, state, and local government efforts improve to provide quality healthcare services and supports in accordance with treaty obligations? And also, let me ask you this. I mean, you all in your respective jobs interact with a lot of tribal health officials. We have an Indian healthcare clinic in Oklahoma City, one of only, I think, 38 in urban areas around the country. It's not in a tribal zone. We have some very robust tribal healthcare organizations, particularly some of the major tribes, Cherokees, Choctaws, Chickasaws made huge investments in this area. So what are the challenges in that arena? What are the assets maybe we have in Oklahoma because we have an unusually robust Native presence compared to other states? Commissioner, let me start with you because that's kind of a statewide question, and then we'll.
I think as far as challenges go, anytime you have, most of the tribes have their own health service. And so anytime you have multiple health services, you're going to have difficulty with coordination and collaboration and delivery of services when you're trying to make sure that you're doing, having uniform coverage throughout the state and no either duplication of efforts or gaps in service. It just adds a layer of complexity that's always going to make it difficult. And, we can give numerous examples of that, but one was, for instance, when we started with vaccine rollout, we were unable to see the federal allocations, how many of the federal allocations vaccines were given in the state through the first part of the rollout. Eventually, they got the Tiberius system to catch up to where we could see that information. But it looked like the eastern part of our state just wasn't getting vaccinated because we weren't seeing those numbers show up. So, it took additional efforts and communication to have those discussions and figure out where we really need to concentrate on our vaccine rollout. One of the good things about it is that, as I think a lot of Oklahomans are, I'm a tribal member myself, and have good relationships with the tribes. And so we're able to really collaborate in a way that is a full force multiplier for us. And, they have their funding, we have our funding, and they have really stepped up. I mean, I can't say enough about their efforts through this pandemic. They were opening their vaccination clinics up to any Oklahoman, not just tribal members, and putting their information in, OSIS and so that we would have a little bit easier tracking of it during the initial part where we're having issues, and or in their health record system, their electronic health record system. And so, like right now we are putting together some of the secretaries of health of the tribes and some other health leaders in the state to really think about and plan how we're going to move forward with public health infrastructure in the state of Oklahoma. Again, they're getting funding, we're getting funding. We want to make sure we're thoughtful about how we use it, that we're all coordinating together. We're not duplicating efforts, just to make sure that we move the state forward in a thoughtful manner and change public health infrastructure. So that is a fantastic thing. And that's a huge force multiplier and really an asset that we have in Oklahoma, that a state that doesn't have the tribes that we have here in the state, they don't have that asset to help them move forward like we do.
Yeah, just to build on what you're saying, and then I'll turn to Phil, you, and to Blaine, but and you wouldn't have necessarily known this because this was a first, but under the CARES Act, tribal governments got over $8 billion, roughly $8 billion. That's the largest transfer of wealth from the federal government to Indian tribes in the history of the United States. And because we have so many tribes of such substantial size here, about 1.8 billion of that went to Oklahoma. So we ended up with we didn't have the mechanism set up for the coordination. I think your point's a really good one, but we ended up with more resources per capita probably than almost any other state. We got more money on the tribal side than any other state in Oklahoma, in America. And we have some facilities. You made the point, Commissioner, about a number of the tribes opening up their facilities to everybody that came, but in a lot of rural Oklahoma, particularly storing this stuff, which had to be kept at minus 80, 90 degrees, there literally weren't the facilities to do it if there weren't tribal hospitals and healthcare clinics out there that had already been developed. So we got to get better at using it, but it was a hidden asset for us in terms of both attracting resources and having infrastructure that would not have been there to deal with the public health care crisis had there not been earlier investments at the tribal level, both by the federal government, but by the tribes on top of that. It's not, they don't just administer federal funds, they put a lot in. But anyway, that's something I spend a lot of time on because it's an area that Oklahoma is quite unique compared to any other state. There's nothing quite like it out there. I know in Oklahoma County, you don't have quite as much interaction since there's no direct tribal governments there, but I'm still there's lots of tribal citizens, obviously, in Oklahoma City and Oklahoma County, and lots of activities of tribal health departments because of that, or the Indian Healthcare Clinic, which is sort of all Native Americans are eligible to go there, and it delivers a lot of care in Oklahoma County. So very interested, Phil and Blaine, on your take on this issue.
Yeah, I can lead. So actually, I was talking to Robin that runs the clinic for the Oklahoma City Indian Clinic last week about possible incentives for vaccination. They're already offering some here for the tribal representatives in this county. I don't know if you guys know how that works, but the Oklahoma City Indian Clinic actually contracts with the other tribes to provide services for all tribal members in Oklahoma County. It's just like, for example, I'm a Chickasaw. There's more Chickasaws in Oklahoma County than there are in Pontotoc County. So there's a big need here, but I wanted to really give them some compliments about how we worked together through this pandemic. We've had Chickasaws, Cherokees, Choctaws work with us on isolation and quarantine, vaccination, testing. We had Southern Plains Tribal EPIs actually here working with us, doing contact tracing early on. So yes, even though we don't have a tribal boundary here in Oklahoma County, we work with them on many other projects. So, you know, we do have those relationships. What we don't have is the infrastructure for us to all work together seamlessly, like between them and us and the state. So, you know, that would be, if you could ask me what I would do, that's where I would try to get it.
Lane?
Yeah, and just to tack on to what Phil mentioned, we do already have good partnerships with what we have here. We actually even have what we call a memorandum of understanding with the Indian Health Services Clinic here for pandemic type stuff or bioterrorism as well. And we work closely actually with Remington Park. I know it's kind of sub-tribal, I guess you would say, but we've done a lot of response activities there in the past as well. And one of the things I would say is a need is, and of course, Commissioner Fry has already alluded to it, and part of our digital infrastructure that we need for our nation needs to connect to the tribes as well, so that we can have that comprehensive picture of whether it's reportable diseases, whether it's immunizations given, and all the kind of health information that we would need to have great situational awareness. We need that comprehensive picture and have that kind of seamless if we can.
That's great. You guys touched on this a little bit earlier, but in the beginning of COVID-19, illustrated the insufficiency of many states' public health laboratory testing capacity and surveillance activity. What specific problems contributed to the challenges that many states encountered? Which problems remain to be addressed by Congress, and what solutions might Congress pursue to enhance public health laboratory testing capacity and surveillance? I mean, it comes up over and over again in our hearings that we just didn't have what we needed. Lane, let me start with you.
Sure, and this is a huge one, and and I'll probably let Commissioner Fry talk a little bit more about the state's public health lab, because I know they've been underfunded for years before this. But part of that is also that digital platform. It wasn't just the capacity at the time; it was how do you report the results back to the health department? How do you report those results back to that person who got tested positive, so that you can make an impact that, hey, yeah, you're positive, you need to isolate, quarantine, or public health could take action. Because we're talking about using faxes to report that and having people go through that and enter that information into our reportable disease database. Part of that is a supply issue. Obviously, we didn't have a way to ramp up the production of testing supplies and the equipment. I think part of it is partnerships with some of the private labs. We need to have some of the agreements that we already have in our disaster response. What we set up, we set up what we call pods to either disseminate vaccine or medical countermeasures. We may need to do some of those same things with labs, whether that's OMRF or CPL, all these labs, that they will be part of this infrastructure to be able to step up quickly if there is a pandemic, so that we can increase our capacity for testing across the state, across the nation. Those are kind of avenues I see that we probably need to invest in.
Phil?
So I wanted to point out something specifically that Blaine brought up, because it was of high priority when we first started. When we first started, everybody was on board, wanted to test, but we would be out of strategic components. Like we wouldn't have the right solutions. We wouldn't have swabs. We wouldn't have all it takes is missing one component and you can't do the testing. So I know at the federal level, I think the federal government had enacted, I forgot what act that was, for providers here to build specific components that we needed, whether that's for testing machines or supplies for testing or vaccination, whatever it might be. I'm sure you'll be able to spout that right off the top of your head. But that's something that we would really like to see. And then, you know, everybody wants to be individualistic, but in this case, I think at the federal level, there needs to be a nationwide health information exchange. That way we don't have issues, because I'll just tell you right now, we still have issues trying to get data from IHS and DOD. So like if somebody gets vaccinated in the state and they've been vaccinated at either a tribal facility or Department of Defense, and they need a vaccine card, I may or may not be able to get the information to provide that for them. So that's something that we need to work on.
Yeah, Commissioner?
This is, again, yeah, I think you both hit it right on the head, but this is a big one. This was a big problem for us. You know, when we started out, we had the ability to do about 100 tests in the state. And they were all done individually, like one at a time. You know, it's called a closed system. So you put the sample in, you run it, you get the answer out. So we had antiquated technology. We had no supplies. And again, there was a worldwide competition for limited assets and supplies that were needed. So, and we had never competed in that marketplace. So in order for us to move forward, what we did was we looked around our state to see who had capability and who had relationships with these vendors. And one of the innovative things that we were able to do was we realized that the animal lab in Stillwater had PCR tests. They had the equipment there. They were running those, and they actually had modern equipment there, and they had established relationships with vendors for their supplies. So we partnered with our universities. We partnered with Oklahoma State University and OU to form a network of our what we considered all our public health lab at that time, in order to be able to acquire what we needed to move forward. Another piece of that was a private partnership. Emmy Labs in Norman, they also had the ability to ramp up and do these things very quickly and move at a faster rate than we did. So we included all those people into our network. And that is really how we got through this, because every time we tried to outsource to another company, it was a disaster. We would overwhelm them, their system. The first day we started sending them supplies, they would call us and say, whoa, we can't do this, even though, basically overrepresented but couldn't do it. So we realized that we had to build up in-state capacity, and that's really how we started. And then use that as a basis to then modernize our technology and start replacing our equipment with equipment that could process a lot more, more swabs in a day. And then, continuing those private partnerships to help us set up pods that were large enough and efficient enough to be able to move enough people through to get the testing done. But it was really continuing that process. And then, of course, we had the bond money that was set aside years ago to build a new public health lab. So we were able to instead of, we're in the middle of a pandemic, instead of just building a public health lab, we're like, we know that this is not going to be the end of this. There's going to be this pandemic, then there's going to be your next zoonotic disease that's going to be coming through, and we need to be able to prepare for that. And Oklahoma really being the perfect place to really set up a national center of excellence, because of, we're talking about food, so agriculture, environmental, animal, and human health all together in one health approach, to be able to do the proper research and surveillance and everything that we need to do to be able to be prepared next time, instead of walking into it flat-footed like we were this time. So those were big issues for us. And I don't know, there's always this division between federal and state and what can be done at a federal level versus state level. But one of the things that really struck me through this whole thing was that, we weren't just fighting this COVID enemy, we were in competition with Arkansas and Missouri and Texas and Kansas. There was no unified effort in the United States for all of us moving forward to try to get some of these things done. And you're right, Blaine, we're still trying to keep people from sending us faxes. We about a few weeks ago, I did an emergency order requesting that all laboratories report to us electronically, because we're still trying to process all these lab results coming in by faxes every day. So it is, I haven't even seen a fax machine in a long time till I came here. So those are all potential issues.
I'm going to ask all three of you about a specific problem area that, Oklahoma does not do well in nationally, and frankly, our country does not do well compared to a lot of other comparably advanced countries around the world, and that's maternal health. I actually saw some statistics. We were like the fourth worst in the country in terms of infant mortality, and there were obvious racial divisions. I think an African American woman in Oklahoma was like 7 times more likely to suffer, infant mortality or to have an infant mortality experience than a white woman. But however you wanted to cut it, it wasn't very good. And we're at the bottom of a lot of statistics, I'm sad to say. But I will say in this area, America did not compare well with other advanced countries in Europe. So, I mean, it's clearly maybe a little more acute here, but it's a big national issue. And it's one that really does, again, highlight some of the healthcare disparities we have on ethnic, racial, economic, and geographic lines. It's also a big difference in rural areas versus urban, suburban areas and what have you. So I'm just curious, what are some of the measures you think we ought to think about instituting, both locally and state, but also resource-wise? What do we do nationally to change those numbers? Because it's terrible to see us at the bottom of a statistic like that, as wealthy a country as we are and technologically advanced. We just simply need to do a whole lot better in maternal health. So I'll start, Commissioner, with you, and then we'll kind of work around the horn again.
So this is near and dear to my heart because I'm an OBGYN as well. But Oklahoma ranks one of the worst in our nation with maternal outcomes, which is terrible. We need to do better. Some of the things that we have improved over the last few years, I will say, and some of that, a lot of that has been through the work from the Oklahoma Maternal Task Force and Oklahoma Perinatal Quality Improvement Collaborative. Basically, they're taking best practices and implementing those in hospitals throughout Oklahoma. For instance, how to handle maternal hemorrhage. Making sure that they have protocols that are evidence-based protocols, standard of care to follow with the medications in the room, close at hand, all the things that they need in order to make a difference. We also I had the great opportunity to work with the developer of Best Birth Project when I was at St. Francis in Tulsa. And we were one of the first 3 hospitals that were their pilot project across the United States in order to see if this way of approaching, it's really a team-based approach to labor and delivery and taking care of that mother through the whole process, from labor to delivery, and now even to the postpartum recovery area. And they found that they did make a significant difference in maternal outcomes based off of that, maternal fetal outcomes. And so we've just, we've been in conversations now and have agreed to try to push that project out into every birthing center in the state of Oklahoma. So it is again, it's a change in the way of approaching labor and delivery. So sometimes that's not easy to do when you're dealing with physicians, because they're pretty stubborn at times. I know I can certainly be that way. And so, but it's a great program. We're very excited about doing that. Also, we have to remember that the substance abuse issues here in Oklahoma have an effect on this as well. And so, the large push that's been done over the last few years on the opioid crisis and other substance abuse problems in the state of Oklahoma have made a difference in this. All these things together, I think, have started us down the right path. So we're making improvements, but we still have a long ways to go. It's really about making sure everyone has prenatal care, which in rural Oklahoma can be difficult. So we have used projects like Project Echo, which helps basically provide the knowledge, share the knowledge with local community healthcare workers on how best practices on how to take care of these patients, and to enable them to be able to take care of those patients in the communities that they live, instead of requiring those patients to drive several hours for prenatal care. And so that, along with telemedicine and the other projects that we have going on in the state, the Best Birth Project and the Oklahoma Perinatal Quality Improvement, et cetera. I think all of those have started to make a difference, but we still have a long ways to go.
Good. Phil?
Hey, so good comments by Commissioner. The basic thing and why you see a lot of our low health outcomes, it all boils down to 2 or 3 things: access to care, education, income. I mean, those are the things that really drive everything. So right now, the programs that we have that are the most successful, especially with either maternal child health or even just young mothers, are the ones that are one-on-one, where somebody actually goes and meets with them, like the Children First program, where they talk through them, like, this is what you should do, this is where you should go. They try to find them care. I mean, basically what they come are 1-point reference systems for them to go try to maneuver whatever it is they have to maneuver. So, the more we can get of that, the better. And I think, our incomes, but we're not going to make significant income or progress until we improve some of our other elements.
Blaine?
And just continue, like I said, access, as they mentioned, good access to care. But poverty is an issue, as they mentioned. So access to food, diapers, those kinds of things. But I think part of it is, we don't have good maternity leave guidelines for our country as well, and even paternity leave, for that to have that support system for when you have a newborn baby. And I think some of that would probably help in some of those health outcomes as well for the whole family, and not just physical health, but mental health, and just help get a better start to the family.
Let me end with this. I mean, I've asked all of you a lot of questions, and but I'm going to turn around now. If you could tell Congress, okay, here's 2 or 3 things you really need to do to improve the public health infrastructure of the country, to position us better for pandemics, but also to position us better to deal with everyday things like maternity. What should we be looking at to change at the federal level? What programs should we emphasize? What new things should we do? Where should we deploy the resources we have? Now, Blaine, I'll start with you.
I'll go with a few simple things and let Phil and Commissioner Fry cover the rest. But again, I'm going back to some of those, start with the digital platforms. What I mean by that too, not just saying, hey, we need funding here locally or as a state, but if some of these were federally important, to have that health information exchange federally, to have surveillance. And what I mean by surveillance, that's syndromic surveillance, that sewage surveillance, some of this information that we really could share. And the higher importance of that would make the input, the information that we receive in those more important. We'll be able to predict illnesses quicker, even terrorism for that matter as well. And as far as the overall infrastructure, you know, a healthier community is going to be more resilient and better prepared for, you know, disasters or pandemics. And so investing into our infrastructure to where it promotes physical activity, you know, not just parks, but, and I know we're doing that some a little bit as a country, doing pretty good, but making it easy access to walk and not always have to have a car, or providing, you know, public transportation and things like that, so people can have better access, but access where they could do it physically and those kinds of things. I think just kind of promote daily health into our lives is definitely would be a benefit.
Phil?
So for me, I think the biggest thing that would really help us long range is a little better funding and stable funding. It needs to stay where you can predict what you have. And that's been an issue for us all along. It goes up and down, and you have planning cycles, and then you don't have any money to actually use the planning. So that, and you know, that goes specifically with FEP or just other just straight up public health funding. And that's where I would put most of it right there.
Okay. Commissioner?
I'd say several things. First of all, you know, right now we have, you know, some really great opportunity as far as one-time funding that's coming our way to help us with this, but most of that is restricted funding. It has, you know, it has specific guardrails about what you can use it for. Very little is unrestricted. Keeping that in mind, but also realizing that, you know, COVID is going to be at some point in the near future similar to the flu, right? As far as we're going to need boosters, we're going to follow it, but we're not going to be probably quarantining and isolating. We're going to tell people if you're sick, don't go to school, don't go to work. If you're really sick, you know, go see your doctor and get your vaccine every year. So we need to have with future funding, if there was more, again, more flexibility with the ability to really look at the whole person and the whole requirements for the state, and to be able to use that money where it actually needs to go would be incredibly helpful. Also, you know, that investment in infrastructure. We know that one of the biggest problems, we've heard it over and over again throughout this whole pandemic, was there was no investment in infrastructure for decades. So even if we start investing now, you know, there's a cost to maintaining that and keeping it up. So we need to have increases in funding towards our public health infrastructure. I would also say broadband. I mean, with the need for the force multiplier that you know, telehealth and things like Project Echo and et cetera bring to our state and our rural communities, that broadband expansion is incredibly important to us to be able to move forward. Those are, I guess, the three big things I would ask for.
Well, let me, number one, just thank all three of you for participating in this. Is extremely helpful. The best ideas usually don't come out of Washington. They usually work their way toward Washington from people that have practical experience on the ground and, you know, in communities and localities and states. But I want to underscore how important, and your perspective is for the Healthy Futures Task Force. Again, too often in DC, we try to think it all up on our own. I found I learned a lot more going to the county and city health department or sitting down with the state healthcare commissioners, and they're telling me what the real challenges are out there and where we ought to deploy the dollars. I do think this, though. I do think there's probably going to be sustained investment in public health over the next few years. And we've had enough scares and now a real live pandemic in a way that Washington is probably going to be more prudent about this. Whoever's running it, I can tell you, we were already starting to have some really good hearings on public healthcare infrastructure pre-pandemic over the last couple of years. So I think this probably is added to the impetus, but I want to thank you. And again, if you guys have other ideas or input, please give them. I know one of the ones which we didn't have a chance to touch on here, but I've visited with some of you individually about is just how difficult it is to maintain the staffing that you need, to both educate professionals and create job opportunities for them and loan forgiveness programs for them. Quite often there's areas other than public health where you can do a little bit better and makes it very hard to maintain a public, healthcare core, if you will, that's sufficient to the need. So I know there's going to be a lot of focus on that as well. And we'll be looking at that going forward. But again, just thanks very much. Appreciate it. And look forward to working with all of you in the years to come.
Thank you.
Thank you so
Okay.
much.
Bye.
Thank you, Congressman.